Welcome to the Navigating the Hospice Cost Report webinar presented by the Visiting Nurse Associations of America. Maureen Laskowski is a director for Simione Healthcare Consultants and has over 25 years experience in the home health industry. She has prepared and reviewed Medicare cost reports for home health, hospice, and home offices. Maureen has developed and implemented strategic costing methodologies to include home health implementation, home office implementation, and direct costing plans. She has performed due diligence on hospice agencies and reviews of Medicare hospice cap calculations. Maureen has also has experience in financial budgeting for hospice and private duty startups. She is a support and training specialist of a CMS-approved Medicare cost reporting software program. Maureen has had experience as Director of Finance for a home care social service agency and financial audit experience in a public accounting firm. I'd now like to turn it over to Maureen to begin today's program. Maureen?
Hi, thank you, Heather, and welcome everybody to the webinar, Navigating the Hospice Cost Report. As we all know, this will be our second year preparing the new hospice cost report forms that came out last year. I'm sure last year you found it all a little bit challenging. I'm going to kind of go into a little bit review, maybe give you some more things to think about as you begin preparing this year's cost reports. So as we begin, just a few tidbits of information, that there are now 40.2 million people in the USA that are 65 or older. By 2040, 20% of the population will be 65 or older. In regards to Medicare hospice payment categories, and you all see this in your agencies, that routine home care is the largest percentage of days that you provide to any of your patients. The number of Medicare beneficiaries receiving hospice care has jumped significantly between 2000 and 2014, up to 47.8%. Here's a few interesting tidbits about the number of hospice users. You can see that the total spending of hospice dollars went from $2.9 million to $15.1 million in 2014, and the average length of stay has gone from 53.5 to 88.2, and we are still seeing that creep up a little bit. I found this very interesting that the number of hospices that there are in 2014, there was 4,092 hospices, and out of that, 3,027 are freestanding, and 506 are home health aid based. Hospice Medicare margins from MedPAC as of 2013, overall it was 8.6%. And one area that we have seen an increase in is the percentage of hospices exceeding the cap. We've gone from 2.6 in 2002 to 10.7 in 2013. And I just want to mention just briefly a little bit about cap before we get going into the cost report end of this. As you know, your cap reports for 2016 are due by March 31st, 2017. If you haven't already done so, you can go into the EIDM system to run your beneficiary reports and your PSNR reports for the self-disclosing reporting. So please just go in there and get those done. And remember that for the 2017 cap, that the 2017 period is the year of transition, so that the bennies and the payments will be counted if you're on the proportional method from the time of 11/1 to 9/30. So now let's move into the cost report, and I'm going to go quite in depth in some of the areas here. So let's start off by CMS 15 parts 1 and 2. This is where basically the instructions for the cost report. Part 1 defines your allowable versus not allowable, all your requirements, and Part 2 is the general instructions on the cost report and their forms, and below is the link to the CMS website. Here's a map of all of the MAC regions. There are 4 MAC regions in the country. So this is, depending on where your MAC is where you file your cost report. Here's just some helpful links to the MAC contractors' websites. They do put information in regards to the hospice cost report and on their website. So please, if you're looking for anything in specific, check out the websites there. CMS estimates that it takes us 188 hours to complete this report, and that includes soup to nuts, reviewing the instructions, gathering the data, maintaining your records, and completing the forms. I'm going to assume that a majority of you out there have 12/31 year ends, which means your cost reports are due by May 31st. Highly recommend start the process now. Don't wait until the last minute. These cost reports, again, are submitted 5 months after the end of the cost report year. It's beneficial to file early. If you file early and there is something wrong with your cost report, you will have a grace period to correct those items, which will help with filing at the last minute and then having your interim payments cut. So be a little proactive, and if you can submit this early, you know, do it. Don't wait till the end of the month. Few key items, just all to keep yourself a reminder is that your data must be on the accrual basis accounting, and all your financial and statistical records used on the cost report must be auditable. Determine which type of cost report you need to file. Most of you will probably file a full utilization cost report. If you're a new provider, maybe not have been in business for the full year. If your Medicare payments are less than $200,000, you can file a low utilization cost report. And if you have a Medicare certified provider number, but you didn't have any covered services during the cost reporting period, then you would be allowed to file a no Medicare utilization cost report. And if you file a low or a no Medicare utilization cost report, there is no ECR encryption, so you basically send in paper copies. And just keep in mind, if you are a new provider, that you must file a cost report. A lot of times we will get panic calls at the beginning of June from a new provider saying that they received a letter from the MAC saying their payments will be stopped, and they have no idea what's going on. So if you are new to Medicare and filing of cost reports, please be aware that you are required to file. The new cost report has expanded level 1 edit errors. There's more checks and balances, which we think will help a lot of providers. And it will help in really filing a more accurate cost report, because we all know that MedPAC and CMS, these cost reports will be used for rate rebasing in future years. So now we're going to get into where we're going to talk a little bit about gathering some of the information and kind of the key areas of information that you need. So your statistics. Your total days, key here, contracted days with a facility, make sure it's by level of care, by payer source. Everything is done on this cost report by level of care and by payer. Your CBSA codes, you may have some time studies, your square footage, mileage, volunteer hours of service, pharmacy charges. And just a reminder, your CBSA codes, they're not on the PSNR, so this is something that you will have to gather out of your billing system. Also, you will need to answer some questions in relationship to malpractice insurance. That was new on the cost report last year. So just be proactive in gathering this information up front so you're not scrambling at the end. If you own an inpatient facility or residential care facilities, you are going to have to obtain some additional information. I'm not going to talk a lot about owning inpatient facilities or residential care facilities, but if you have any questions, feel free to contact me after the webinar via email, and I'll be happy to answer any of your questions. Key financial information that you're going to need is going to need your balance sheet, your income statement, your trial balance, and your PS&R report, which will be run out of the EIDM system, and this will be report type 810. Just remember, there's a lot of detail in this cost report. Your revenue is done by level of care, Medicare, Medicaid, other, your physician services, nursing home, room and board. Please make sure that you're tracking both the revenue and the expenses in separate accounts and not offsetting the expense against the revenue within your GL system. And flu vaccines, and we'll talk a little bit later about the flu vaccines and the hospice cost report. Examine your trial balance. Look to see if the following costs are easily distinguishable, especially on the salary end. You need to have nursing administrative, your volunteer coordinators, your physician administrative services, your RNs and your LPNs must be broken out. You cannot lump them all together. Your costs for spiritual, bereavement, fundraising, marketing. Your employee benefits should be identifiable, and keep in mind too that workman's comp is a benefit and should be classified as so. Some of the other key expenses that we'll need to gather is your staff transportation, your contracted respite and GIP, routine medical and billable medical supplies. Are you separating those expenses out within your GL system? Make sure that you do. They go in different spots in the cost report. Pharmacy, as we all know, is still recorded as a general service cost center. Other key expenses you're going to need is your DMEA, your labs, diagnostics, nursing home, room and board, fundraising, marketing, identify that malpractice insurance. So here's an overview of the cost report worksheets, and I'll just give you a minute just to kind of go down, and you can see that, you know, again, this is our second year into this cost report, so this is not new to most of you, but for those of you, it may be your first year preparing a cost report. Here are the corresponding worksheets. The big difference with this new cost report that went into effect is that everything is done by level of care. So moving on, let's talk about the expansion of the general service cost centers. So in the past, we had 5 general service cost centers, and those are the ones that are highlighted in blue. You can see that they've added many new cost centers, so we have gone from 6 to 16 cost centers. And most of you should have these cost centers, except with the exception of maybe laundry, linen, housekeeping, and dietary. Usually you see those if you have an inpatient facility. Next, we'll talk about the expansion of the non-reimbursable cost centers. From here, we've basically gone from 3 to 11. The key here is the nursing home, room, and board being tracked separately, as well as marketing and advertising. So those are 2 key areas that most of you should have on your cost reports. And lastly is the patient care cost service centers, which is reported for each level of care. So you will have a worksheet for continuous routine, respite, and GIP. And within this, you will outline all of these cost centers. So as you can see, it's a lot of work to gather this information. The more detail you have in your general account, your chart of accounts, the better off you're going to be. So moving on, we'll talk a little bit about some of the key worksheets here and stuff that is new. So for example, worksheet S1 is basically is for a hospice identification data. It's basically information that identifies the hospice. This is where you would enter the new items such as your malpractice insurance premiums and answer all of those questions, and your CBSA areas. And remember that the CBSA codes are not listed on your PS&R. So this is what Worksheet S1, Part 2, and Part 3 of the cost report looks like, and this is the gathering of the statistical data. Note that you will get an error message if you have costs on line 25 of Worksheet A3 or A4 and you don't have statistics listed above under the contracted costs. So just make sure that if you have contracted costs, you have contracted stats, and that the statistics in Part 3 must be included in the statistics in Part 1. Worksheet S2 is the hospice reimbursement questionnaire, and these questions basically replace the old Form 339 that you used to have to file and sign separately. So now when you file your cost report, there's only one signature required, and that's on the certification page. This Worksheet S2 will ask you some questions about your organization. Basically, the first set of questions deals with if there's any change of ownership or termination, or have you terminated from the Medicare program. Next set relates to your financial data and whether or not you have a financial audit, if it's prepared by a CPA, what kind of financial statements do you do. And again, you must disclose if there's a difference between the total expenses and revenues reported on the cost report and the financial statements. A lot of times you may have some reconciliation items. So moving along, also asks about the PSNR data, and finally, who has prepared your cost report. So let's move on to Worksheet A. Now, Worksheet A is really it's the reclassification and adjustment of the trial balance of expenses. And Worksheet A is where the total expenses of the agency are accumulated here. The cost center lines are segregated into the three sections like we talked about: your general service cost centers, your direct patient care cost centers, and your non-reimbursable cost centers. Your general service cost centers include expenses incurred in the operating the program as a whole but aren't directly related to patient care. Your direct patient care service costs are reported by line on worksheets A1, A2, A3, and 4 by level of care. And then we have our non-reimbursable cost centers, which include the cost of the non-reimbursable services and programs. So briefly going to go through some highlights of these general service cost centers and what you need to take a look out for. So line 1 is basically your capital related cost, building, and fixtures. This is where you would record any of your rent, your building, your depreciation, your insurance. Again, as I said, I'm not going to go into if you have a inpatient facility. So if you do have those, there's a couple little different rules that you have to pay attention to and where those costs need to go. Line 2 is your capital related movable equipment. Again, this is for your leases, depreciation, personal property taxes. Line 3 is your employee benefits. Line 4 is your administrative and general cost centers. And just please note here that do not include marketing or advertising costs on this general and administrative cost center. These costs should be reported in the non-reimbursable cost section of the cost report. Line 5 is your plan operation and maintenance. Lines 6, 7, and 8. They're common if you have an IPU unit, so probably most of you will not have these costs within your cost report. Line 9 is your nursing administration, and the key here is that this cost center includes the cost of overall management and direction of the nursing service. So if you've got a nursing administrator that's also doing visiting, then that visiting cost gets reported on line 28 with the RNs. So just keep that in mind, that you must distinguish your nursing administration costs from your direct care costs, especially if your administration may be wearing 2 hats or helping out within the field. Line 10 is for your routine medical supplies. The key here is that it's not traceable to an individual patient. Line 11 is your medical records, and line 12 is your staff transportation, and this is primarily for mileage paid to employees or for vehicle lease expenses. Moving on, we have line 13 is the volunteer service coordinator, and here is where you would report the salary costs of the volunteer coordinator as well as the recruitment and training of the volunteers. So remember that you are required to have a volunteer service coordinator, so you should definitely have costs on this line 13 of the cost report. Line 14 is your pharmacy. Again, this is for the cost of drugs, both prescription and over-the-counter. Line 15 is for your physician administrative services. Basically, the cost of the medical director and physicians of the IDT team who participate in the establishment, review, and updating of plans of care, supervising care, and establishing policies. Line 16, other general service cost centers. Yet to use this on a cost report last year. Don't know if we'll use it this year. And line 17 is for patient residential care services, and this would be, again, if you had a patient residential care. So now let's move on and talk about some of the direct patient care cost centers. Line 25 is your inpatient care contracted, and these are costs paid to another facility. Line 26 is your physician services. Line 27 is your nurse practitioner, and this would be for the cost of nursing care only. If your nurse practitioner is performing physician care services, those must be reported on line 26, the physician service line. Line 28, this is where you would distinguish your RNs, and line 29 is your LPNs. So please, you must distinguish between the cost of the RNs and the LPNs. We don't see a lot of PT/OT/ST within hospice. Some of you may have some of these services, but the majority of hospices, we don't see a lot of dollars in these cost buckets. Line 13 is medical social service, which you will all have. Line 34 is spiritual. 35 dietary. 36 counseling. You may or may not have those. You'll all have line 37 for your hospice aides, line 38 for your DME, line 39 is your transportation, and line 40 is your imaging services. 41 is labs and diagnostics. Line 42 is now for your medical supplies non-routine, and these supplies are supplies specific to a patient's plan of care. Lines 44 and 45, don't get confused here. It's palliative radiation therapy. It's for patients that are on the hospice benefit and not in a palliative care program. Line 60 is bereavement, costs incurred for services both prior to and after the patient's death. Line 61, this is where you would report your volunteer program costs, such as supplies, food for meetings, etc. Remember that the recruitment and training costs, though, of the volunteers are reported on line 13 with the volunteer coordinator. Most hospices, you will have fundraising. Those fundraising costs will be reported on line 62. For those of you who have a palliative care program, those costs must be segregated out and be reported on line 64. We are seeing more and more hospices across the country opening and having palliative care programs. Line 66 would be if you have a residential care. Line 67, advertising. This is key here. This is for non-allowable community education, business development, marketing, and advertising costs. Do not report these costs under the Administrative and General Cost Center. They must be reported on line 67. Line 68, telehealth. Haven't seen a whole lot of this in any of the cost reports we prepared last year. Line 69, some of the bigger hospices own and operate thrift stores, so if you do, please include those costs on line 69. Line 7B, this is a key expense, your nursing home room and board. These are for patients on hospice benefit living in a nursing facility, and you must include the full amount paid to the facility. Do not offset the revenue to the expense and report it on Worksheet A. You must include the full expense. I can't stress that enough. Had a lot of providers last year that were scrambling to try to figure out what their true cost was, what their true revenue was, because everything ended up being netted in one account. So this is just really the flow of the cost report on Worksheet A. Your separate columns, we really just have two basic columns now. It's your salaries and your other. Then you will do any reclassifications, and then you will do any adjustments. Remember that the direct patient care cost services will flow directly to Worksheet A from the sub-worksheets A1 through A4 for all columns. Worksheets for direct patient care cost centers are your worksheets A1 through A4, your continuous, your routine, your respite, and your GIP. And again, those individual worksheets can consist of the same 7 columns on Worksheet A. Highlight basically it's your salaries, your others, your reclasses, and your adjustments. Key here is remember that all costs must be broken out by level of care. Your smaller hospice agencies typically will have contracted inpatient costs, routine home care, and some continuous care costs. Information can be captured by use of time studies, statistical methodologies. Some of you may code some of your invoices up front to get the expense into a greater level of detail. We develop spreadsheets for tracking costs. In inpatient costs, make sure that they're tracked separately between contracted facilities versus your own facilities if you do own a facility. We do have a couple of providers that have their own IPU unit, but in some cases they sometimes have to contract out. So just make sure you segregate those costs as well. Line 25 is your inpatient contracted. Contracted costs paid to the facility for respite and GIP. Some challenges that you may find that if the hospice staff is seeing patients in the contracted setting, you need to capture their costs on Worksheet 8.3, line 28. Just, keep in mind that you must break out the cost of staff seeing the patients in the facilities. Line 26, your physician services, direct care only, includes both physician and nurse practitioners. Nurse practitioner is providing physician services only. Remember, don't include costs of the administrative and general supervisory activities, your plan of care, or your IDT meetings, and you may have to utilize sometimes a time study here. The nurse practitioner, line 27, remember this is for direct nursing care only. Some challenges you may encounter is that your nurse practitioner could be wearing 3 hats. She could be doing physician administrative services, physician services, and nurse practitioner services. So how are you carving out their time? How are you going to get her costs in the proper buckets? These are just some common things to think about. Again, here's the RN and the LPN. Can't stress this enough. Please, you need to segregate those costs. We have providers that tell us that, oh, I only have a little bit of RN. I'm going to keep it all on RN. You must. Please segregate out those costs. Some of the challenges an RN can have by the end of the day that she's seeing patients basically on all levels of care. So how are you capturing her time? PT, OT, and ST, again, we don't see high volume of these services in hospice. So we have found that it's been pretty straightforward, and if there is cost, it's usually in routine home care. If you're a small hospice entity, No doubt you're encountering this challenge with your medical social worker. She's wearing 3 hats. She's doing social work, she's doing spiritual counseling, and she's doing bereavement. So how are you segregating out her time? Are you using time study, or are you using some other method of allocation? Spiritual counseling, again, smaller agencies, clergy may be performing both spiritual counseling and bereavement. Again, try to carve out those costs as best as you possibly can. Dietary counseling and other counseling, we see, some of this. If you're doing any pet, music, or art therapy, that is really considered a non-reimbursable cost center. Your hospice aides and your homemaker services, those are reported on line 37. Again, you need to capture them by level of care. So, whether it's a time study or some other methodology. And if you're contracting for those services, again, find a way to carve out the level of care. Line 38 is your DME and oxygen. A challenge here is if your patient is moving from like routine home care to continuous home care, how are you going to proportion that cost? Are you going to do it on level of days? Are you developing internal spreadsheets? These are just things to think about. Patient transportation, basically your ambulance cost. The cost report instructions say that you can proportion these costs based upon the level of days. That is the statistic on Worksheet B1, so you can use your total days for this. Lines 40, 41, and 43 are your imaging labs, diagnostics, outpatients. Again, challenge, costs are very patient specific. So again, how are you distinguishing between each level of care? Line 42, your medical supplies. These are your non-routine medical supplies. Remember that it's patient specific. And the cost report instructions do allow you to allocate this cost based upon the level of days. Again, we talked about this before, your lines 44 and 45, your palliative radiation and palliative chemotherapy. Don't be confused by the term palliative here. These lines are for reporting radiation and chemotherapy costs for the patients who are on the hospice benefit. Okay, worksheet 6 is where you're going to do any reclassifications. You're going to use this to shift costs between the cost centers as needed. You can leave the worksheet blank if you have no reclasses to be made. Most reclass the costs, try to make them directly on the trial balance. So this way here, the cost report doesn't get ugly looking if you, because you can get into several reclasses. Some of the typical reclasses you may have to do. You may have to do your nurse practitioner based upon the level of care days, registered nurses, your homemakers and your home health aides, volunteer services. I would say almost every cost report we have done a reclass for the volunteer coordinator. The reclass will be necessary, and that's because the A&G cost center is prior to the volunteer cost center in the step down of the cost report. And because the statistical basis for these volunteer service coordinator is hours, a lot of times those hours are spent on administrative functions, so you will definitely need to do a reclassification for this. Another area which we did a lot of reclassifications was for plant operation and maintenance. Again, because of the way the cost report is laid out, you cannot allocate square footage to A&G in this case because of the way the cost centers fall, so you may have to do a reclassification. Another big reclassification that we did a lot of was the transportation, because the transportation cost center falls after A&G. So basically, we would reclassify anything that wasn't direct patient care related out, so that all that was left on the staff transportation line, which would then go through the step down, would be the direct patient care services. Worksheet 8 is basically your adjustment to expenses. Basically here, any now allowable expense needs to be entered into this worksheet. Key questions: are the expenses prudent and reasonable, and are they related to patient care? Again, remember, you must do an 8-8 adjustment for your Medicaid room and board revenues, so please make sure that you do this. Next few slides are some key examples of adjustments to expenses that need to be offset. Really, the most common ones that we see and everybody usually has is the bad debts, the lobbying fees. Some of your association membership dues may be for lobbying fees, so those are non-allowable expenses and must be offset. If you're a for-profit entity, income taxes paid is a non-allowable expense. Worksheet A81 is where you would report any of your related organization and home office costs. And just remember that when doing this, the transactions must be reduced to cost. Home office organization costs would also be reported on A-81. And a home office organization is basically a chain organization with 2 or more entities. Some providers have home offices because that's where all their back office operations are. They may have centralized intake, accounting functions. So this is where those costs would be reported if you have a home office. In a home office, you always have a separate provider number if you have a home office cost statement, or I should say most of the time. Moving on, let's talk about Worksheet B and B1. Worksheet B is the allocation of the general service cost centers to the level of care and the non-reimbursable cost centers. And Worksheet B-1 is basically the statistical basis for allocation. So just a little bit history about the worksheet, the flow of Worksheet B. The line numbers on Worksheet B don't replicate those of Worksheet A, and that's because they roll up all the direct patient care service cost centers into one line for each. So now let's move on and let's talk about gathering the statistics for your B1 allocation. So these are the key stats that you're going to need. You're going to need your square footage statistics. You're going to need detailed floor plans, your gross salaries, your inpatient facility days, your patient care hours, your patient days, mileage, your volunteer hours, and your pharmacy charges. The order of allocation for the statistical basis, capital related, is your square footage. Capital related movable equipment can either be dollar value or square feet, and I'll talk about this a little bit later. Employee benefits is done on gross salaries. Administrative and general is accumulated costs. PL&O is square footage. Laundry, linen, housekeeping, dietary, basically seeing if you have an inpatient unit, and the statistics are listed there. Your nursing administration is your direct nursing hours. Your routine medical supplies is patient days, and medical records is patient days. Staff transportation is done on mileage. Volunteer service coordinator is done on your hours of services. Pharmacy charges, physician administrative services, patient days, and any other general service cost centers that you may have opened up, specify the basis. And then last but not least, if you have a patient residential care services, it would be done on inpatient facility days. So here's just what your worksheet B1 for the statistics allocation basis looks like. And you all probably encountered some challenges as you tried to prepare last year's cost report. The step down isn't the friendliest in some areas. For example, capital-related building and fixtures. Step down does not allow for costs to be allocated to direct care staff by level of care. Routine, continuous home care, you may have to develop alternative methods. You may have done some reclassifications on Worksheet A6. I mentioned before I would talk a little bit more about capital-related movable and equipment. The statistic is dollar value and or square feet. If you had previously filed the old CMS 1984 hospice cost report and you use square footage, then you could continue to utilize square footage. However, if you are a new provider, you must use dollar value unless you request a change in the allocation method to the square footage. And again, same challenges, doesn't allow for the cost to be stepped down by the direct level of care. Employee benefits, the statistic is gross salaries. Keep in mind that if you made any reclassifications and or adjustments to salaries, be sure to take them into account when you are doing your statistic for gross salaries. Administrative in general is based on accumulated costs. Most of your software vendors out there, it populates the statistic automatically. However, remember that if you have contracted GIP or respite, you don't have to allocate A&G to this cost center. So you may have to do a manual override to the statistic within your cost reporting software. And if you have any questions regarding that, I suggest that you contact your vendor. If you do utilize HFS, we can help you out there. We're very familiar with HFS. Plan operation and maintenance. Again, this is another area of challenge. The step down doesn't allow you to allocate your costs to your administrative in general or direct care staff. So you may have done some reclassifications. So just be aware that you might want to move around some of those costs before you step it down. Again, if you have an inpatient facility, you may utilize laundry, linen, housekeeping, and dietary. And if you have an inpatient facilities, you need to track your days by routine, respite, and GIP. Nursing administration, the statistic for this is patient care hours, use of payroll hours of direct patient care workers. The nursing administrator is supervising. Basically, consider your RNs, your LPNs, and your home health aides. You may not have a true statistic, so you may convert your payroll dollars divided by an average hourly wage to come up 2 hours. Staff transportation is mileage. Remember, you have to account for your mileage by level of care. It's best to do a reclassification for all the other mileage other than the direct patient care service costs. Then what I would do is I would take that total dollar amount that's left, convert the dollars into mileage, divide the mileage divide the total expense on your TV by your mileage reimbursement rate. If you're not tracking the mileage, that's the lesser of the two evils, I would say. The volunteer service coordinator, now remember that under the conditions of participation, a hospice provider is required to maintain records on the use of volunteers. So we have people say to us, oh, I don't have the statistic. You are required to track this. While there's no formal reporting requirement to CMS, providers will be required to produce this information upon survey. Key things to remember here, that it must equal 5% of the total patient care hours. You may have to do a reclassification, as we talked about in worksheet for worksheet A6. But again, you all should have the hours of service for the volunteer coordinator to use for your statistics. Pharmacy charges, they're still considered a general service cost center. Things to think about, charges are required to be included on the Medicare claims. Are you applying any markup, and are you taking into account any delivery charges? So again, you must have a statistic to step down the pharmacy expense throughout the cost report. If you request a change in allocation to your MAC, this may be done 90 days prior to the end of the cost reporting period. We did see last year some MACs request some different allocation methods. Basically, the change of the order of allocation. There was inconsistencies among the MACs as to what they accepted. We saw MACs accept everything 100%, and then the same MAC, then a different MAC deny everything 100%. So just keep that in mind if you decide that you are going to request any deviations from the statistical allocations. Now, after we've compiled all of this information, worksheet C of the cost report is the calculation of the per diem cost, and the average cost per diem is calculated by level of care in total, as well as the cost per day of each level of care. They have each level of care and an aggregate total average cost per day, whereas in the old cost report, it was just the average cost per day. Worksheet F is your balance sheet. Just make sure it balances. You should get a level 1 error edit. If it doesn't, make sure that the fund balance agrees with worksheet F1. Worksheet F2 is your statement of revenue and operating expenses. Again, key here is that your gross patient service revenue is reported by payer, by level of care, as well as your contractual allowances. It was a little challenging last year on some providers, kind of lumped all the contractual service, contractual allowances together in one line item in their trial balance. If you can, please segregate those out. If not, you may have to do it based upon a percent of total of your revenue, but you have to identify those contractual allowances by payer source. Other key revenue items you must be tracking is your hospice physician services, your room and board. If you're doing any palliative consults, your donations, rebates, refunds, investments, grant appropriations, any other type of revenue, grants, fundraising, etc. So if you're a facility out there, I'm not going to read through this whole slide, but these are some challenges that we have found that those facilities have been encountering. So just keep this in mind as you're doing this if you're a facility. And again, if you have any questions, don't hesitate to contact us. So as we're winding down here, some helpful hints for you as you begin to prepare your cost report, and I can't stress the importance of you being proactive, and please don't wait until the last minute. You know, a lot of data goes into the cost report, so really, you know, it's early February. Mostly everybody should have their December financials closed out. If you're waiting on a financial audit, that, you know, might hold you up a little bit, but otherwise I strongly suggest that you start gathering the data and begin preparing your cost report. Some helpful hints: run your PS&R, compare the Medicare Hospice stats, make sure that you're capturing all levels of care. Physician services, does your PS&R show that you've done physician service billing? If so, make sure your physician services are carved out on your cost report. Go back, gather your contracted GIP and respite stats. Do you need to make additional reclassifications? Did you do any continuous care? A lot of agencies don't realize that they did a little bit of continuous care till the end of the year when they start looking at their PS&R. So look at that PS&R, and if you've done any continuous care days, go back and do that reclassification on Worksheet A6 for your RNs and your home health aides. Again, make sure you're distinguishing the difference between your RNs and your LPNs. Make sure you exclude overhead allocation from your contracted GIP and respite. Worksheet A, you basically get an error message if you don't have any of these costs reported. Key costs that all the level edits look for within the cost report are that you have something on the employee benefit line, administrative and general, plan operation and maintenance, your volunteer service coordinator, your pharmacy, your RN, your aides, your DME, your labs and diagnostics. So make sure you have costs on these cost centers, and as far as the plan operation and maintenance goes, you may have had initially some costs reported on there, but you may have then taken those costs, especially if it was like utilities and you're using a square footage statistic of 100 to A&G, you would then reclassify that back just to the administrative and general cost center. Nursing home room and board offset. Can't stress this enough. Make sure your revenue and your expenses are segregated within your trial balance. However, make sure that when all said and done on the cost report, that worksheet A, line 70, column 7, is not a negative number. If it's a negative number, then something's wrong. Because we all know that you usually reimburse 95% of your cost on the nursing home room and board. So you should not see a negative number on this worksheet, on this line number 70. New this year, flu vaccines, report those in a non-reimbursable cost center. Currently there's no settlement page within the cost report. There has been a new transmittal that was just issued on February 3rd, and that's the second highlighted website there. And basically the change request, you know, shifts the change of the basis for the hospice payment vaccine to 95% of the average wholesale price. And last but not least, check your cost per diem. Check your routine home care costs. Check your average cost per day. Does it make sense? So as you've gathered all your information to prepare the cost report, just ask yourself, review your general ledger chart of accounts to accommodate capturing any additional expenses that you may have found that you needed that you didn't have. Look at your computer systems. Are you using them to full capacity? Will you need to make some system modifications? Or you may even have to make some process and system changes. So that concludes the end of our webinar today, and we will take any questions that we have at this time.
Great. Thank you so much, Maureen. If anyone has any questions, please feel free to chat them through the chat feature of the GoToMeeting window. We did have a few questions come in during the presentation that I'll go ahead and get started with while we wait to see if any additional questions come through. The first question is, do I need to track volunteer hours?
Yes, that's a very good question. Yes, you do need to have your volunteer hours. You need your hours in order to do the B1 allocation step down of the volunteer coordinator. And remember that you're required by Medicare to track your volunteer hours. So yes, you definitely need to gather this statistic.
Great, thank you, Maureen. The next question that came through is, where do I get the CBSA codes from?
Okay, since the CBSA codes are not listed on the PS&R report, you'll need to go into your internal systems, your billing system, to get your CBSA codes. You know, depending on the size and volume, you may have one CBSA code, or you may be doing business in several CBSA codes.
Great, thanks for that clarification. The next question that we have is, must I segregate my nursing administration costs from nursing visit costs?
Yes, if you have a nurse administrator that is doing both administration and visiting costs, you must put the cost of her visiting on the appropriate RN worksheet by level of care in the cost report, so that it then gets accumulated within the cost per day. You do not want to leave it all in administrative services.
Great, thank you. The next question we have is, how do I obtain my PS&R report, and what report do you need to run?
Okay, the PS&R report is obtained from the EIDM system in Medicare. Most of you should be registered within that system, and then when you go into the EIDM, what you want to do is you want to go into request a report. You want to request a summary. And for hospice, the report type is 810. That is the report that you would request to get your PS&R.
Great, thank you so much. It looks like there are no questions, additional questions at this point. So if there are no other questions, I'd like to take this time to thank everyone for joining us during today's webinar. I'd also especially like to thank our presenter, Maureen, for sharing her expertise, time, and commitment to making this a successful program. Thank you again for your participation, and I hope you all have a wonderful afternoon.
Thank you.